Povabljeni, da zasedete počasi svoja mesta. Hvala lepa, začenjamo s konferenco. Prvi gost nas že čaka na neposredni povezavi in predlagam, da počasi zasedete svoja mesta. Hvala. Ko imamo zdravje, radi rečemo, da imamo vse. Naše zdravje.
This is what we like to say. But our own health depends to a large extent on the power of our own immune system. And when that system cracks, or when that system even breaks down, we look to the healthcare system for support. But even that system, the healthcare system, needs resilience. It needs resilience to the challenges existing and upcoming. Ladies and gentlemen, in the wake of the epidemic, we have given even more focus to health. The epidemic has reminded us of the paramount importance of a health system that is flexible, responsive, and which at the same time can anticipate the challenges of the future. A health system that is accessible, high quality, and focused on the needs of the individual. Now, in recent years, health systems have been under an immense pressure. At the same time, great opportunities for innovation and adaptation have emerged. And building on this momentum, it is worth working on sustainable mechanisms to support the transformation and adaptation of our own healthcare systems to the current and future challenges. This is why the 12th Strategic Conference on the Value of Innovation this year focuses on future-proof healthcare, healthcare that is able to take on the challenges of the future. Now, this is a concept that embraces the broadest view of the future, encompassing new technologies, new models of care. It touches upon supply chain management and includes an ethical perspective. Only through a proactive, innovative, and flexible approach can we build a healthcare that will be able to meet new challenges while delivering the best possible care for patients, for all of us. Welcome to everyone who has kindly joined us here at the Tsarka Ryabzon Club. It is very nice to see so many faces here, and my heartfelt welcome goes to everyone who is with us online.
And all those who are with us online at the Strategic Conference, Value of Innovation, this year on the topic of future-proof healthcare. Together with our esteemed panelists, we will look at directions towards resilient and responsive healthcare adapted to the future needs. We need accessible, affordable, qualitative, and patient-centered healthcare system. Za uvodni nagovor pa prosim člana uprave Mednarodnega foruma znanstveno-raziskovalnih farmacevtskih družb, današnjega gostitelja, gospoda Domna Groznika.
Mr. Domen Groznik, the floor is yours.
Spoštovane gostje, spoštovani gosti.
Distinguished guests, ladies and gentlemen, welcome to what is now a traditional strategic conference, The Value of Innovation, organized by the Forum of International Research and Development Pharmaceutical Companies for the 12th year in a row. We are facing a period marked by a rapid development of technologies and a changing health environment. We are also living in an aging society marked by global health care crisis and other types of crises. Therefore, future-proof health care is not just an important concept, it is an essential and urgent concept. We are aware that the future of healthcare is not back there somewhere in the distant future. It is a challenge that we need to address today. We all know that the challenges faced by the healthcare are multifaceted, starting from an increasing expenses in the healthcare over to the aging population, the disease burden of chronic diseases, and the need for a fair and equitable healthcare. But within these challenges arises the opportunity for innovation and transformation, an opportunity to reform the very foundations underlying the healthcare. Future-proof healthcare is not an unimportant concept. It represents a change in paradigm in our approach to healthcare. It involves the integration of the most up-to-date and cutting-edge technologies based on data and based on collaborative healthcare. It involves the building of resistance, flexibility, and adaptability. Our healthcare in this way will be able to withstand the test of time and challenges alike. The potential of healthcare, future-proof healthcare, is unlimited. Imagine a world where personalized healthcare, supported by genomics and precision diagnostics, directs individualized treatment plans. Imagine an integrated ecosystem of devices collecting health data in real time, giving the patient and healthcare providers invaluable insights into proactive care. Now just imagine a future where artificial intelligence and machine learning revolutionize clinical decision-making, allowing faster and more precise diagnosis and at the same time improving patient health outcomes. Now, in order to really utilize this immense potential, we must also address ethical, regulatory and societal consequences. We must ensure that the benefits of future-proof healthcare will be available to each and everyone. If we succeed in that, we will bridge the gap in equity in healthcare. And it is our joint responsibility to support an environment that builds on equity, that builds strong foundations for the future of healthcare. Now, today's conference is the 12th edition in a row, and today we will have the opportunity to discuss various pertinent aspects of future-proof healthcare. You will be able to talk to eminent international and domestic experts. We are going to listen and discuss what the European Union has done and what we in Slovenia have done so far and can do in the future. By joining our forces, we can build a healthcare system where there are no barriers and no limits for the healthcare, where the health and well-being of each individual are in the core of our mission and action. And therefore, once again, welcome. Thank you for taking the time to be here, either in person here or online. I would also like to thank in advance to all the speakers who will share with us their immense and invaluable knowledge and experience. I believe that the 12th Strategic Conference on the Value of Innovation will bring all of us even closer together. I'm looking forward to fruitful discussions about the future of the Slovenian healthcare system. Thank you very much. Thank you, Mr. Groznik, for giving us a glimpse into the future. How far away and how close to each and every one of us it is depends on where we are, what we do, and how well the policy and decision makers are listening. Now, in building more resilient healthcare systems, investments in the development and implementation of new innovative solutions in healthcare financing, organization, human resource management, and service delivery are of key importance. Now, how to build healthy and strong foundations for sustainable healthcare, this is something that will be presented by our first today's keynote speaker, the Director of Health at the Copenhagen Institute for Future Studies, Mr. Bogi Eliassen, who has joined us online. Mr. Eliassen was the initiator of the first population genome project, FARGEN, to sequence the genomes of the entire population of the Faroe Islands. As Director of Health at the CIFS, he sets the stage, diving into topics such as the future of genomics, data, digital functions, and their integration with health. And this is based on a holistic vision of shaping the future personalized health paradigm as a part of ambitious projects and networks around the world. He received the HIMSS Future 50 Global Award for his work in 2019. He initiated the Nordic Health 2030 process and also has a key role in both the Global Future Proofing Health Index and Movement Health 2030, aspiring to improve health by applying the new health paradigm. Building fair models is at the heart of his work. Bogi is also the Danish chair of the World Chairs of Bioethics. He calls himself a knowledge broker whose expertise lies in combining various fields of knowledge. Distinguished Mr. Eliassen, we are looking forward to discussing with you what knowledge will be key to building sustainable healthcare and what the way is towards building bridges between the personal, individual health and public health, in order for us to act more preventively, including by reducing the burden of avoidable diseases.
Thank you. Thank you so much, and thank you for inviting me here today to this very impressive event. So, as probably was introduced, Bogi Eliassen, Director of Health at the Copenhagen Institute for Future Studies. And we are a 50-year-old think tank that was established by a former Danish finance minister, Knud Christensen, and the first OECD General Secretary. I will not dwell so much on our past, but just saying that we are really working with combining different disciplines and different sectors and also between countries. So coming back to the talk of today, which is really on how do we get health better? How do we get it right? But it's also very important to remember in this discussion that we have came a long way. So probably 150 years ago, the average lifespan was 30 years. Now in many countries, we are reaching 80, as well as in Slovenia. But we are getting increased disease burden that we have a hard time dealing with. So this is very much a question about doing the right things right, not just doing the right things or doing the things right, but doing the right things right. And we can also quote Stanislav Lem saying that there are no answers, only choices. To live is to possess a future which will become your present. And this is the essence on how we work. So we are based on megatrends when we work, But the megatrends are something that you also, if you are very focused on it, also can fold and mold into your own direction and can work with. So working with the future in this way is trying to see what can you shape and what do you need to accept, and in that way try to build a better future for all of us in that. Then when it comes to the challenges we see ahead, it's also about a paradigm shift, which I think was said before, but also how do we approach this? So what is the role of health? So if we start saying that health is actually the most important societal pillar to create equality, equity, fairness, sustainable growth, and prosperity, it's also to realize economy of well-being, but maybe most of all to reduce avoidable disease burden. And this is the challenge that we have. Likely 30% of the disease burden we see in most countries is avoidable, either by prevention or by earlier and timely intervention when we know these things are coming. For instance, when you have the first chronic disease, how do you avoid the second one? Another part is that we have a high focus on innovation, which is really important, but we are not applying. There is a lot of things we are not applying that we know. And we have estimated in our movement health approach that 80% of health challenges that health systems need to deal with are more or less similar around the world, but still we make it country by country. So how do we apply better? How do we learn better in order to make impact? And I'll just show you this commercial from an old commercial from the US from the 50s. And I'm not showing you this in order for you to think, oh, did we really think that way? I just want you to take this with you back home and say, what are we doing today that to our kids and grandkids in 20 years will be as absurd as it is for you looking at this commercial today? Because we are working with health in an absurd way in many instances. So we also need to remember that knowledge and experience are about the past and decisions are about the future. So while we need to be scientific, we need to be evidence-based, we also need to really understand that the future is not the same as the past. So how do we get that flexibility in? We have ourselves worked a lot in the Nordics with this concept called Nordic Health. And also working much more globally, but always with a preventive approach to health. So how do we reduce the disease burden so we can work better with the resources that we have? So it's not necessarily about first thinking about more money, more financing into health, but repurposing how to work with what we have. And then, of course, some countries need more money, others do not, like the Nordics. But we could also ask ourselves that as we have increased our lifespan from 30 to almost 80 in many countries, we have accepted that the disease burden for each individual also increases. Just the last 30 years on most of the OECD countries, we have gained 10 years of longevity, whereof 5 come with extra disease burden. So try to think if we did the same in traffic, in trains, in cars, in planes. So when we expanded the network of traffic, would we accept that the deaths of the traffic accidents just exploded? No, we would not. So how do we rethink these things? So there is a burning platform that is based on increased disease burden, which I just explained. It's also very focused on end-of-life solutions and has a focus on disease, not on health. And this has a huge impact. So if we take this example on just looking at a chronic disease, we know that we need to be much more to the left in order to have a timely intervention, to have something that gives more dignity and much better lifespan and health during the lifespan for the person. But we only begin to pay when we are very light, very much on the right side. So when it's more expensive, it's more complex, and the impact for an individual and also the value for society is much less. This also comes off that we invest in high-end care for the later stages in disease, but also when we invest with Risico money into health technology, we always push for fast on the market, solve really, really burning platform issues, which is very late in the disease areas. Now, I'm not saying we should not help people with diseases. Of course we need to, but we also need to begin to focus to migrate to the left, so to become earlier, use the technology, use the knowledge, use all the data that we are producing to start earlier in it. So what we are facing is what we normally call wicked problems. So it's socially complex. There is no clear solution. It's very difficult to clearly define it. It does involve changing behaviors, and it's not the responsibility of only one stakeholder. We also know that around 70% of health benefits, it's outside of what we would normally call the clinical health system. One of the focus that we have had the last year is really to look at secondary prevention. There are many definitions, so let me just say that here we are focusing on once you are in a high risk or you have the first chronic disease, how can we help with slowing the progress or stopping that disease progress, but also slowing and stopping the progress towards a secondary and a second and a third or maybe fourth chronic diseases, because the complexity and the burden of disease, but also the economic burden very much also comes off that people have several chronic diseases. So how can we begin to stop the growing disease burden by reducing avoidable disease burden, the ones that we actually can see and we could approach? And
I'm sorry, excuse me, Mr. Bogi, we don't
of course
see your
this
slides.
requires that we, sorry?
Excuse me, I'm interrupting you because we don't see your slides.
You don't see my slides?
No. I know you have prepared them, so that's why I'm interrupting you, and I'm sorry. But I think they are very interesting slides, so we would really love to see them.
I'm very sorry about that. It said it was sharing. Does it?
Let's try again. Okay, now we see the slides. Now we see the slides, yes, thank you.
Okay, sorry about that. So real-world data, real-world evidence, and evidence-based care for one, and precision public health are concepts that are coming in very fast, and especially with AI that we have seen over the last months exploding, is going to help us realize these promises. I just need to see. And in the end, this is very much about the best possible quality of life and well-being during the lifespan. So how can we focus on getting that right? It's not about hospitals per se, but how do we get the outcomes in it? In that, there is a very crucial question on saying, what do you want? Is it the best health system so that we can treat anything with any complexity at any given time in a country, or is it actually the healthiest population? So these things are probably in a mix that we need to figure out how much of each, but you probably do not get 100% of both. So that's also a discussion we need to take. And we already have a lot of health concepts that have been agreed on globally for a long, long time. So sustainable development goals, One Health, health and all policies, social determinants of health, economy of well-being, which we also can begin to set up in policy approaches, which include several of those things. Also, the 5-5 model I will come in later on is the new biology with genomics, other omics and biomarkers, preventive approaches with avoidable disease burden, the equitable perspectives with universal health coverage and leaving no one behind, and health determinants, where we have social, of course, we have One Health, and other determinants like commercial and digital. And of course, there are the data and digital and tech with data for better lives, for instance, from the World Bank, with data governance as a core, FAIR principles, and technological, societal, and human readiness as well. This does require, and we also have a high push from new players, but also new payers into health. So where do we work with health? How can we work cross-border? So the big ICT companies, they are investing heavily into these areas and will also have an impact whether we like it or not. So our responsibility is to work with the ones who can provide value to societies in a way that is both sustainable and ethically sound. And we also come into what I call the $100 tipping point. Probably a genome sequence is $100 if you do it in bulk already now in some places, but it also will be so. But there are also several companies working on assembling all the relevant data for a person for around $100. So the thought experiment here is, what is it you can do when you get these data and you have AI and you can combine it in different ways and the cost is $200? compared to a CT scan, which is much more expensive. So this will open totally new ways of working with and thinking health. So what are the focuses that we see? So it's a well-being over the lifespan, but it's also maybe a shift from a lifespan to a health span. So how healthy can you keep people in this part? And it is, of course, much more patient-centered, and value-based care is beginning to focus much more on outcome and not just the supply chain in it. Personalized is in there with precision, and a stronger focus on prevention, where the secondary prevention probably is the point where we can start much more efficient today. In the Nordics, we ended up with a conclusion with some 35 major stakeholders in the Nordic that we should aim at 2030 by saying half of the health budget should go towards prevention. It's 5-5 because the Nordic countries use 10% of GDP on health. So meaning that trying to push that half of it would go towards primary, secondary, and third-tier prevention by 2030 as a goal. Then you could say, is that realistic? I don't know. Maybe it's pushing that way, but even if we only reach 10 or 15, it's much, much better than today. Another principle that we pushed very hard in the Nordic was what we called 80-20, meaning that in a given point in a society, you have more or less 20% that really need intensive care and 80% that you, with a little bit of health, can keep healthier much longer if we do that. So how can we focus on both keeping these 80% healthier longer, so we can use much more energy and better energy on the 20% that really need it, because we are not helping them well enough. And the 10-90 principle is also to push the fact that the focus, especially of companies, is on the 10% richest in the world, leaving the 90% outside of that. So how can we look at the 90% of the world and really make impact for them as well, also from a business point of view? So the question here is, how do we create societal value by helping individual systems as well? Because if health is an investment, it's also something you build societal value with. So with a healthier population, you also get more dynamic into the society. One of the things, and sorry, I'm getting a bit complex here, I don't know if you can see the screen, but one of the things that we also did in the Nordic program here is to say, okay, what happens if the person is their own biorepository or biobank and digital repository, just looking at data that's already accessible out there today. So what if you as a person, you could have access, of course you need AI to this, and just noting that this was made in 19, so AI was not that advanced at that point. But if you give a person access to their genomics, to their different societal factors and environmental, micro and macro environmental factors that can impact them and their personal behavior, so you actually can help people, give them a tool to take more care of themselves. So those who can, the 80%, and that of course requires both transparency and traceability, accountability, the consent. There are a lot of ethical things we need to consider, but if we want people to have a more sustainable behavior for our health, we also need to help them with tools, not just help the system. But working with that would also require a sustainable health model where you connect the aggregated data and individual data, so you enrich both ways. Because our systems today are very much based on very static data points and are not really enriched in the way that we actually can work with data today. So a sustainable health model would probably need that you work the personalized health and the public health in a combined way, which we actually have tools to do. Just a very few concepts. The first one, Tverspo, I know it's a difficult name, is a hospital in Denmark which has used a lot of predictive on what they know in the data to see how do you then manage the staff at hospitals, looking at if you have football in the city, is it good or bad weather, is it winter or summer, what was the push on the hospital the last 2-3 weeks, what was the push on the GPs, and with that you can actually predict very well what you need of staff for the next week on that hospital, and this is based on AI models. In phase 5, we are working quite hard with a new way of doing decentralized clinical trials with persons in the center, which probably is the future. And so you let people be at home as much as possible. And Data for Better Lives is also very much on data governance in order to use data in order to get better lives for everybody in the world. Often we are complaining to the political responsibility that that's not high enough, and we always see these cycles of 4 or 5 years, depending on you are. But I will claim that we actually need to push much more on individual responsibility, public sector responsibility, corporate responsibility, and civil society responsibility, because that's where the longevity is. So yes, we need to demand for the political system, but we also need to take much more responsibility ourselves in where we are. So it all comes back to data governance. We are moving from an analog model to a digital model. We are not prepared for that. Our legal frames are not prepared for that. So consent, transparency, traceability, and accountability are key. So these are ways we need to push and enable the use of data and digital functions. It doesn't work to try to fit that with analog thinking on frames. What we did with human rights, and we spent 200 years on this, was to protect the individual from states, from organizations, and from criminals. And it's more or less the same we need to get right in it. So we don't have to overcomplicate it. I know it's not easy, but we need to simplify without making this simplistic. And one of those things is the health literacy. So how do we get the population, the decision makers, but also the healthcare professionals really to understand and get a high health literacy that is digital and we can use to work going forward. And that's very much about leadership and getting capacity building into the system in a totally different way. So going back to the Nordic health, where we are really focusing on a sustainable approach that we started in 19, we built the Nordic on 5 values, 5 Nordic values: trust, creativity and innovation, openness, individual responsibility with solidarity, and cultivation. So how do you give people capacity to work with knowledge in the system? I'm not saying that these should be the ones that we use everywhere. I'm just saying that it's very important to build on some pillars when we go forward. In the movement health, which was also mentioned before, we started with 4 focus areas on improving access to quality of care across the lifespan, and the new biology with advancements in science and biotechnology, really on the data and digital solutions, which is our main focus today, and of course to build it sustainable in the country. And in the end, the sustainability is key. But sustainability is a lot of things. So what we are trying to do is to create and build with partners. So how do we do this sustainability piece? Because it's about carbon footprint, it's about waste, it's about better use of resources, it's creating value, it's decreasing the disease burden with health span. So we actually need less input into the health system, and to decrease the avoidable disease burden. And of course, you have to see health as an investment. The huge challenge we have here is that we both need much more hyper-specialization at the same time as we need holistic system thinking. And this is very hard. We don't really have the leaders today who can do this, not on any level. So we also need to develop those parts. And as the famous Honda said, vision without action is a daydream, action without vision is a nightmare. And because we are missing some of these things, we often end up in challenges which are nightmare-like. And this also comes back to that, oh, now my slides got their own life. I'm very sorry, I'm going a little bit back to finish off my talk. And this also, here we go, sorry. This also comes back to that we need readiness in the system to be able to work with these parts. Technological readiness, societal readiness, and behavioral readiness needs to be in place for us to be able to go forward. And often we underestimate that these actually need to be synchronized. And here, 2 main ways of thinking. So technical change is when you do a reductionistic approach, when you know what you do, you have an Excel sheet, you do your Gantt chart, and then you just work. It's like building a house. Adaptive change is what we are standing over for, that we know we need to change, but we also know that we don't really know what to do before we are in the process. And everybody wants to do that. But what we do is that when we give funding, we set the frames for technical change to work with adaptive change, and it fails. And this is why we see so many failures in these kinds of projects and work. And we call that work avoidance because everybody is stressed, but nobody does anything that is of value in it. So we are actually in a beyond repair situation. So where we need to rethink for systemic change in systems and behavior, but we should not reinvent the wheel all the time. There are so many things we can use. So the end of here is that health needs to move from cost to investment. So my really question is not if we can afford to do the future costs of healthcare services, but if we can afford not to invest in keeping people as healthy as possible. And the most important thing for me is always that if we want to change things, if we want a new paradigm, we actually need to ask the questions before we seek the answers. Thank you so much.
And that's why this is the time for the questions. Torej, prvo vprašanja, mislim, da prevoda ne sliši.
Opportunities for some questions. I don't think Mr. Eliasson hears the translation.
English language, Bogi?
No.
No? Okay, so we'll ask for the questions in English. Not everyone at one time, just one question at one time, okay? So we see the first hand for the first question. The lights turned on. Yes, we have the first question. We just need the mic. Thank you.
Thank you very much. Petra Dosinovic-Bonča. I have a question. You talked about the role of prevention and the 5-5 rule. Currently, if we look at the expenditures for prevention, we have the data based on national health accounts, and the data actually indicates that we, in Europe, dedicate about 3% of overall expenditures to prevention. But this does not include secondary prevention and tertiary prevention. So I was wondering, what are your estimates? Where are we in Europe relative to the goal that you talked about?
Yeah, it's a little bit of a difficult question in it because nobody has really looked at the data on that part. But if we look at primary care as such, that average in Europe, I think, is between 25 and 30% in that part. And of course, everything in primary care is not prevention. But let me try to be a little bit more clear on, for instance, a case to look at. So when you have if we take Denmark, where you have very good data, so you can actually see when a person has a chronic disease, the pathway to the next chronic disease and the third chronic disease. So these are things, when you look at the big data, you can actually see patterns. I'm not saying it happens for everybody, but it happens for most of them. So the thing that we want to focus on in our first step in secondary prevention is to say, okay, if we have this knowledge, can we then go in? So this will be more timely and more precise to help these patients to not progress more. Coming back to your estimation of the data, which was a very clear question, my estimation when we go in to work with it in that way would probably be 10 or 15% if we go to work with it in that way. But what is missing, and this is the whole point of changing the paradigm, is that we are not thinking prevention in the care as we could in order to reduce the avoidable disease burden, so the 30% that we have in most countries.
Thank you very much. Do we have another question for this very interesting first panelist? I think we heard a lot of interesting things today. Especially we'll take home the thought that health is an investment for all of us. So if there are not any questions here at this moment, another question, yes, please.
Thank you for a very fruitful and interesting presentation. My question, I'm quite fascinated that you merge all those activities in the Scandic area. So we know that traditionally those countries are cooperating daily, but what were the reasons that you merge all your activities and you have common vision? Do you think something similar should be also applicable in Slovenia, which is a small country, but of course we are having commercial activities with our neighbors, Italy, Austria, Germany, and similar. So would it be recommendable that we, for example, do some similar effort in our environment? Thank you.
Yes, yes, thank you so much for the question. I think it's a very important one to stress. So of course, there has for decades been established collaboration between the Nordic countries, but it's and the Nordics are also fairly active in the European or the EU collaboration, and these are two different, how can I say, dynamics. The Nordic is more on the culture and social part, so more softer than the European part on that way. But there is I don't know if it's a commonality between the cultures, because there are also big differences, but it comes more back to the point I mentioned with that probably 80% of health challenges that we have around the world are very similar. So there's a huge benefit in collaboration, learning and doing things here. The other part, so there are two other parts which really triggered this work in 19. So one thing is that we are moving from analog societies to digital societies. And if we want to keep the welfare system as we have, it actually needs to be rethought through. So because the solidarity in an analog system is geographical. In a digital system, it's both geographical and not geographical, because you would begin to work, for instance, with rare diseases around the world and these kinds of things. And then it also comes in that with the huge investment in personalized health via genomics and big data, the populations are too small, and this would also cover for Slovenia. So working with 2 or 5 or 10 million people is simply too little in order to get the real power in working with the new technology in it. There are some things you can do much better, much deeper, and connect much better, but there are other things where you really need to be connected into a world in order to make the impact and the learnings of working with both the new biologies or genomics and others and with the data. So for instance, lung cancer already has at least 20 sub-diseases with different biological traits in it, and this will happen with most diseases where we become much more granular in it. So that was one of the other reason in it.
Thank you very much. Mr. Eliasson, maybe a short question?
Yes.
If not, I would love to see you, Mr. Eliasson, next year here in Slovenia, because I'm sure when the lights go down, we have much more questions for you. So you're welcome next year, okay?
Thank you so much. Thank you so much. And enjoy the day. And sorry about the slides.
No, great.
I can share,
we would love to see
the
first. Can you show us one of the first slides about the? You were talking about an advert 20 years ago.
Yes.
We were all wondering what that was.
Yeah. Let me see if I can get back into that. Can I do that? So I need to.
Bogi has lots of monitors there, I think. That's why he needs to find the right slide.
Let me just do it in the brutal way, and then we do it. Are we getting back? So you can ask me a question while I'm working on a non-very digital savvy way.
No, I was just wondering if we can see you live next year. That's the main question. Yes.
So here we go. Here.
Oh, yeah, we were. I think we were close to that one.
So here is the question. When you get the questions in 20 years from your kids or your grandkids, that will make you really embarrassing. embarrassed. So what are you doing today, which will make you feel like this?
Thank you again.
Thank you so much.
Hope to see you next year and have a
I hope
great
so
day.
too.
Yes.
Thank you.
Goodbye. Bye-bye.
Goodbye.
Mr. Bogi Eliasson will be with us, will stay with us through the two next panelists. Nadaljevati moram v slovenščini, mislim da.
I'm going to continue in Slovenian. Now, the healthcare industry is facing many challenges, some of which have been addressed here today, from rising costs and aging populations over to new diseases and global health crisis. Building a healthcare system that is repeatedly flexible, innovative and sustainable could ensure that patients, that we all receive the best possible care. And this is why we are speaking about health care, because we are caring for our health. In addition to technological and logistical considerations, future-proof healthcare must also address ethical issues, as new technologies, such as the genetic testing and others, are becoming more widely available. Providers need to consider the ethical implications of using those technologies, including the issues of privacy, informed consent, and social justice and equity. Our next speaker, therefore, will be Ricardo Leite, the founder and president of Unite Parliamentarians Network for Global Health, a global platform of current and former members of parliament, congresses and senates present in more than 95 countries, and an official partner of the World Health Organization. He's vice chair of the Parliamentary Network on the World Bank, IMF, and global ambassador of the G20 Health and Development Partnership. He's the chair of the Center for Global Health and the Nova Information Management and Data Science, and a guest lecturer at the Nova Medical School. For many years, Ricardo has been an advocate, public speaker, and author on several matters of health policy, public and global health, as well as global and local governance and digital transformation. He is a specialist in infectious diseases. He has been a member of the Portuguese National Parliament since 2011, and just recently he was appointed CEO of the International Digital Health and Artificial Intelligence Research Collaborative, IDAIR, in Geneva. We are happy to have him today at this year's conference, where he's going to speak about the main challenges in moving towards sustainability in healthcare.
Well, thank you so much for the kind introduction. It's a great pleasure to be here among all of you. It's my first time in Slovenia, certainly not the last, but first times are always special. And I'm happy to be spending this first time with all of you. And I have this tremendous challenge of speaking to this dark room a little bit before lunch. So I'll try to keep you all awake. To speak about the challenges we have ahead of us, we've heard many things that I agree with. I'll just try to complement what we heard with some concrete examples, and also sharing a bit where I come from in Portugal. And we created a national health service following our revolution in 1974, which aimed, built from our constitution, it aimed to become a universal health platform, very much inspired by the British NHS. And throughout the years after the revolution, the mark of the SNS, which is our NHS, which was 1979, you can see life expectancy continued to rise. We saw that health outcomes generically got better. You can see that Portugal was presenting infant mortality rates that were actually above average in Europe, and almost at sub-Saharan levels before we had a national health service. And today Portugal is a reference when it comes to infant mortality rates. So these are some examples of how we were able to achieve, with universal health coverage, interesting results, and doing that spending much less than average OECD countries. I'm going to be sharing some data from OECD. Eric, I'm sure, who will be speaking afterwards, will follow up. But this shows that actually we are spending significantly less, especially when we look at public expenditure, than OECD countries. So when we look at this study from 2014, it's almost 10 years old, but at the time, it's particularly relevant to look at it because it was at the end of the financial bailout that Portugal went through when IMF had to bail out our country following the 2008 financial crash. And Portugal's health system was actually, when crossing health outcomes with expenditure, Portugal was among the top 15 health systems in the world. So those are all positive outcomes. I would argue that we invested tremendously on the quality of our healthcare professional training, and that was the main cause of success, along with, especially during the first years of our national health system, an integrated health system. But moving forward, we have many challenges, as was said by our kind presenter. And the truth is we have a challenging demography. When you see here in Portugal, today, the active population is around 6.6 million people, with 2.3 million at the age of 65 or older. But in 2080, if everything continues as it is, we'll have around 4.2 million people in an active age and around 3 million people over the age of 65. Well, in Portugal, as in many countries, we have a pay-as-you-go pension system. So the active population of today pays the pensions of today. There's this idea that when we pay to Social Security, that they are saving the money somewhere so we can get it back when we get into retirement. That is not the case. It is the taxes that are paid today that are paying those pensions tomorrow. This creates a tremendous challenge, along with all of the health challenges that we've started to hear. And Slovenia is a bit better when it comes to an aging population, but you will be facing similar challenges moving forward. But I can see that you're having more babies than we are, which is a good sign. We see that with the rise, the older your population, the bigger the challenges when it comes to non-communicable diseases. And you see dementia. Portugal is going to be most probably the third biggest country when it comes to dementia prevalence among OECD countries. Slovenia, fortunately, is better, but you can see the number is also on a rise as most countries. When you see elderly care, both our countries are below OECD average. When it comes to capability of receiving long-term care, Portugal, sadly, is at the bottom of that list. So not only are we having the oldest population, one of the oldest populations in the world, but at the same time, we are very illy prepared to have an institutional response if needed. And we see, for example, the main causes of mortality. It's no surprise that cardiovascular disease is, of course, the main cause of disease around the world, and then cancers and respiratory diseases playing a very, very important part. And we see that among these top killers, it's quite shocking that we also see metabolic diseases on the rise, the challenges of obesity, the challenges of diabetes. We have 10 million population in Portugal. It is estimated that we have 13% prevalence, 1.3 million out of 10 million with diabetes. That alone is a ticking time bomb that will explode in our hands. And diabetes, from a public health perspective, is more than a disease. It's a reflection of social condition. It is a direct consequence of poverty and inequities and needs to be addressed. And also when we talk about mental health, which are on the rise, particularly after the pandemic, we have seen that 1 in every 5 children, teenagers in Portugal, have some form of mental health challenge, and we're seeing these trends around the world. And then we have this other problem, or challenge, if you will, which is the need for a health workforce that can respond to the needs. And I'm showing you a table, which was a projection made in 2014 of how many doctors, family doctors we would have in Portugal, and the number of patients or citizens that would not have access to a family doctor. And you can see here that by 2023, it was projected that 500,000 Portuguese citizens would not have access to a family doctor. The thing is, the richer countries in the world are importing doctors, nurses, and other healthcare professionals from our country, you are feeling the pain too. And instead of 500,000, we have almost 2 million Portuguese citizens without access to a family doctor. The German government is paying for German courses in German language to third-year medical students in Portugal, so that when they finish their course, they are offered a job immediately, earning 5 times more than they would earn in Portugal. This is one of the biggest challenges that we will be facing in a hyper-specialized world of the future, as we heard before. Another challenge is the way we distribute our healthcare workers. We normally look at data in terms of national distribution of healthcare workers, but most of those healthcare workers are in the big urban centers. Distribution across the country regionally, as you can see here in Portugal, and in Slovenia you also see a similar phenomenon, is that beyond Lisbon and Porto and Coimbra, which is our third biggest city, most of the region has below average coverage. But the most significant one is the distribution within the health system. And this, in the blue bar, the dark blue bar, you can see represents hospitals, and the gray bar represents primary care. So we're always saying primary care is the base of our health system. Primary care is what we want to invest more, but actually, when it comes to looking at hard data, 2/3 of our healthcare workers are working in hospitals, which should be the last place where patients go. The hyper-specialization of hospitals have become the entry point for our health systems, which is a reflection of a broken health system, which is not a health system. We have built across the so-called West disease systems, systems that lead to more and more disease. And when it comes to nurses, then, because of the challenges that I mentioned, we are below OECD average, although we actually train more than we actually needed. Just between 2015 and 2022, Portugal trained 13,000 nurses, and we exported 15,000 nurses. Okay? This is an issue we need to talk about here in the European Union. We have to talk about in the global health space. So I've shared with you some of the challenges. Now let's look into the future. And there are many projections that show that there's going to be a rise of costs, inevitably, with the technologies, personalized medicine, everything we heard before. All of this is amazing and fascinating. Somebody has to pay the price. And we see it as an investment. But what this study interestingly shows is that actually there are 2 ways to take this challenge ahead. Either you can continue business as usual, and in the case of Portugal, we'll go up from 6% GDP to over 14% GDP in 2060, or we can actually perform the reforms that are needed and keep expenditure below 10%, which means hopefully making it sustainable. In other words, if we do nothing, the system will break, it will not be sustainable, and only people who are rich, or at least have some resources, will be able to have access to the kind of care they need, while others, well, they'll be left on waiting lists. That's the Americanization of health system that is happening in Europe, which is exactly the opposite that our social values had always defended. We were proud, but the way we have built our health systems is a trap that we need to get away from. And so I believe the basis of what I'm going to say next is based on the European social model, which believes in universal coverage, equity and access, the offering of high quality of healthcare, and solidarity in funding. But to fix health systems, to make sure that they are sustainable, resilient, they transform themselves from these disease systems to becoming systems for well-being, systems promoting health, we actually need to go back a few centuries, back to the history, back to Hippocrates, even before him, and understand what was healthcare all about. And the goals of medicine were very easy back then. Promote health, preserve health, restore health when compromised, and minimize suffering and malaise. Then the Industrial Revolution happened in the 19th century, which completely transformed the world, in many ways for the better. We continue to make cars the way we did more than 100 years ago with Henry Ford. This thing is, business schools in the last century, particularly in the 1970s and 1980s, started looking at Japanese car makers and say, these guys are very efficient. why don't we import these management models into healthcare and transform healthcare to become more efficient too? And that led to what I like to call the industrialization of healthcare, in which we created this dogma that the more surgeries we perform, the more hospital visits that happen, the more treatments we provide, the more tests we do, the healthier the population. But in the middle of all of that, somebody forgot to measure results. And what has happened? Well, we saw a rising of healthcare costs and a rising of burden of disease, risks of insustainability, which lead to compromising our actually putting at risk our universal health coverage, which leads to worse health, particularly for those that are most vulnerable, for those that are more poor, and this leads to a rise of inequities. So the gap between the rich and the poor actually rises instead of health systems helping to close the gap, as we always saw health as the main driver for development, as the main social ladder in societies. And that's why Michael Porter at Harvard Business School with his team came up with the idea of value-based healthcare, looking at, saying that in healthcare, the days of business as usual are over due to the social inequities, raise of costs with technology, demographic pressure, the need for qualified healthcare workers, chronic diseases, and the rise of the burden of disease. So they took away my my animations. So the second carrot was supposed to appear only after, but I'll get you through it. So the first carrot that you can see at the left side of your screen was the carrot of incentives. You can call it financial incentives, you can call it any other form of incentive that you may use for the people managing a hospital. And today a hospital in this industrialized view is a factory, where we actually pay for more surgeries, more hospital visits, more treatments, more emergency room visits. And the more you treat, the more money you get. And so we're actually creating incentives for more disease. And what I would argue, and that's the idea behind value-based healthcare, is getting that carrot from the left side to the right side to where the patient is, looking at health outcomes, PROMs, patient-reported experience measurements, and outcome measurements. And I'm using cartoons because I speak with politicians. It normally gets the message better. I'm not underestimating your intelligence. But we can see here a very concrete example from my country where measuring results actually works. So this is primary healthcare data. And in Portugal, we have a real-world scenario where we have more or less half of our primary health clinics, doctors and nurses get a salary no matter what they do. And the other half, we have contracts based on health outcomes. So they actually have incentives. And those are what we call family health units. And that's what you can see here, USF-A and USF-B. In USF-A, we measure results but don't pay incentives to see if they can work in this model. If they are successful, then they move to B, in which they actually get a financial incentive. This UCSP, the one on the left side, there is no financial incentive and no measurement. So when a study was conducted, we saw that only 35%, 37% of the hypertensive and diabetic patients were controlled in the setting where there is no measurement and no financial incentives. In the middle, USF-A, we measured results with no financial incentives. It went up to 52%, 59%. And when we put a financial incentive on top of that, it went up to 64, almost 70%. And what this shows is that just measuring gets better results. It almost doubles your results. And if you put a financial incentive, you actually get even better results for your patients. So when people tell me that measurements don't work, and that financial incentives don't work, and looking at outcomes don't work, I show them this. Another example many of you may know from ISHOM is looking at prostate cancer surgery. And mortality in prostate cancer surgery is very low. 95% of patients survive. But then a Martini clinic in Hamburg, in Germany, decided to look at outcomes that the patient cared about, like sexual dysfunction, like urinary incontinence. And they said, why don't we start measuring these outcomes? And what they did was they started measuring, and they started changing their surgical interventions and performance. And when we see the average outcomes in Germany and Sweden, when it comes to 1 year incontinence, 43, 50%. At Martini Clinic, it's only 6.5% 1 year after surgery. Or when we look at 1 year severe erectile dysfunction, 75, 80% of cases in Germany and Sweden, which are very good health systems. 34% at the Martini Clinic. So let's pretend we all have prostates for a second. And if we did and we needed surgery, where would we want to be treated? In a random hospital in Sweden or Germany, or at the Martini Clinic? Mortality is the same, but I'm sure that all of you would want to go to Martini Clinic because we all want to pee when we want. We all want to have to continue to have sex because living is more than surviving. It's quality of life, but you have to listen to patients. So I actually disagree with the idea of patient at the center of the system. The patient has to be everywhere, from the board meeting, from the decision process, from the negotiation, from the definition of what outcomes mean. At the end of the day, we are only here to serve the citizens and the patients. Everything else has to work towards them. We don't need just this idea of a whole bunch of experts around the patient. We need the patient to be part of defining what success means for them, because what means success for them means success for everyone. And so this leads us then to an analysis of health outcomes versus cost. And this graph, you can see here that the purple line represents the evolution of outcomes versus cost. So on the axis, on the vertical axis, you can see outcomes. On the horizontal, you can see cost. And of course, in poorer countries, if you put a little bit more money, outcomes go up exponentially. But it gets to a point more or less at Singapore, one of the most efficient systems in the world, where it doesn't continue to go up. No matter how much money you put, it's a plateau. It's interesting. And even at the US, it drops a bit. With value-based healthcare, I think we'll get the green. It'll go up. With the same money, we'll have better outcomes, but it'll plateau too. And there's a reason for this. And this is my critical take on value-based healthcare, the way it's been designed. It's because the fact that we continue to focus on disease, I only have 1 minute, but I'm going to ask just for a bit of tolerance. The fact that we focus too much on disease leads us to the fact that we are seeing a rise of that burden, because we are not intervening at the societal level. And so the question is, going back, how do we get to that red line where we continuously get better health outcomes at the same cost? And so to address this, we've heard it, we need to look at what actually impacts an individual's health. Be it the clinical factors, which is 10% of what impacts our health. That's what doctors and nurses see when they have the patient in front of them. The genomic factors or biological factors, that's 30%. We see personalized medicine is going to be addressing this, but we're still a bit away from this. And 60% are exogenous factors, our behaviors, where we live, the environment in which we work with. And that represents 60% of our health. So actually looking at determinants of health, at housing, working conditions, all those factors, we know this is critical, but that is not addressed by our health system. So the carrot that value-based healthcare system says it has to be at the patient, I would say it has to be in the community. And we can use community-based outcome measurements, I like to call them CBOMs, where you can actually monitor, measure outcomes in your community, and then you can create incentives. So it doesn't matter just to control your diabetic patients and your hypertensive patients. You actually need to avoid new cases of diabetes and hypertension. You need to lower the burden of disease, prevent everything that is preventable, cure every disease that is curable. And to do this, we need a technological platform. And I had a lot of things I wanted to get into. Fortunately, Eric is going to follow me, and he'll be able to get into further detail. I'll jump a few slides just to say that when we look at the 60, 30, 10% ratios, this represents a lot of data. And so to deal with all of those data, truly we have an opportunity here, which is evolving our health systems that can focus on becoming advanced clinical support systems. And for that, of course, the rise of cognitive computing and artificial intelligence is an important part of that. And we've seen Watson from IBM or DeepMind from Google and so many other technologies that are rising. At the end of the day, they do three main things. Understand natural language and human speech. They generate and evaluate hypotheses for better outcomes, and adapt and learn as we use them. The idea is not to substitute humans. It's to make sure that we get the computer screens out of the way in the office, we can look at patients, become more humane, and leave the administrative work and the hypothesis generating to the machines, so we can task shift the boring stuff and get back to what matters as healthcare professionals, focusing on the interests of the patients, using knowledge and data as drivers to fuel these engines of support decision-making. I had some examples of how this works. I'll jump this. But at the end, we have the rise of this digital healthcare triangle, which is focusing on sustainable health, so risk reduction and wellness, changing these disease systems to focusing on well-being and quality of health, digital medicine, looking at an infocosmos of healthcare, and molecular medicine, as we've heard, focusing on precision diagnostic and precision treatment. And of course, the 5G revolution that is working in telecommunications is transforming the way we use the internet. So until now, we used to go online. Now we are part of the internet. This is a huge transformation that will influence everything we do. And so data is going to be critical as we move forward, and we need to understand the power of data, and we need to educate the people to understand that giving blood and giving data can both save lives, but we're still not there. And so understanding that data is the electricity of the 21st century, without which none of the reforms we're talking about will actually work, we need to create incentives that get people to want to participate. Why not even think about models in which states are going to make so much money if they create health data agencies, they can give away dividends through IRS to their citizens? Why don't we create financial incentives for citizens to participate in this data sharing, data solidarity approach? And that's why I actually took on this role as the new CEO of IDARE, the International Digital Health and Artificial Intelligence Research Collaborative, based in Geneva, as a neutral platform working with WHO and hopefully being able to work with Slovenia moving forward, so that we can make sure that we guarantee better research, but also access of responsible digital health and AI solutions that can help this transformation where outcomes over costs leads to better quality of life and well-being for all citizens, improving health, reducing costs, and improving care across the board. Thank you very much.
Questions? Do we have any questions? Maybe about C-bombs at this moment, or about carrots? Tanya.
Yeah, hello, my name is Tanya Španić. I'm a patient representative, president of Europa Dona. I'm really happy that you addressed patient-centric healthcare and how this is taken into account, because I strongly agree with you that patients should not be in the center, but it's all around. And when we talk about personalization, especially, well, oncology is my field, so I can talk mostly about it, we really need to start treating the patient, not the tumor, biomarker, and everything that we can get with genomics and all other tests. My question for you would be, where do you see maybe this going through prevention and behavioral changes to the treatment? How can countries like Portugal and Slovenia can improve and maybe move closer to Sweden or Denmark with their outcomes?
Well, I don't know if anyone really has fixed the problem when it comes to measuring outcomes, to be honest. And I've heard many times that, no, first we need to consensualize what are good data sets, so then we can actually start moving forward. And I've been hearing this conversation for 15 years now. So I would say, why don't we start with the data we have? And why don't we start actually organizing ourselves? And I can share you an example from my country. During the financial crisis, we had this huge problem where every hospital has their own electronic health record, everything works in a bit of silo approach. So what did we decide to do? The Ministry of Health decided to create a health data platform, which is a cloud-based system, and told every hospital, clinic working in the country, saying, if you want to continue to operate in our country, you can use whatever system you want, as long as you send the following data sets from your health system to the cloud, which is then organized. I continue to see that as a very interesting solution. I think there's other technologies that we can use to give it more power to the patient, like blockchain or others. And of course, the data that exists is very much focused on old school, mortality-based indicators. But as we move forward, creating that basic infrastructure and creating what I believe is a necessity, which is a health data agency, can help actually galvanize that kind of transformation that you need. Many times people say, if you only had 1 year in the Ministry of Health, what would you do? And my answer is, after long thought, I always say I would do two things, and that's emergency and infrastructural response. On the emergency side, I'd find ways to use the whole of the health system, public-private, together to respond to the immediate needs in terms of family doctors and waiting lists. But on the infrastructural side, if I only had 1 year, I wouldn't have time to fix the whole governance structure of health system, but I would have time to build a health data agency focusing on health outcomes, focusing on wellness and quality of life. Because that is the basis on which then we can build new governance, new financial models. And if that health data agency has one mission, one North Star, which is making quality of life better for each citizen, focusing on well-being, then that can be the starting point to go from a disease-driven system towards a system that actually promotes the well-being of all citizens. I hope that helps. And maybe we can do this more at a European level, not just national.
Thank you very much. We have another question at the back.
I was hoping you could expand a little bit on the challenge related to workforce shortages. So what are the discussions that are happening in that regard so you don't limit the free movement of workers in the EU?
Thank you, Tiasha.
Well, that's a very hard question, and nobody has an answer. But what I can tell you is the following. I'm against ending the free movement of people. It's that I do not believe will fix the problem. We see that when you try to limit people's movements, they find a way to get out. We've seen that over history. It's not the way to go. So it's creating incentives that actually try to understand what is important to the citizens. I have seen colleagues of mine leave public health services to go into the private sector, earning exactly the same salary. And I ask them, why would you do such a thing? And they tell me, well, I'm more respected, my work is valued, I get to choose my schedule, I can be closer with my kids, I can pick them up at school, I have my own office, basic things. It's a question of respecting the work. And what we see normally is governments taking a top-down approach. Okay, let's create these incentives. And then you see they don't work. So we have to turn the table around and ask the people we are training, what is important for you to come on board? So that's one angle. So on the policy governance side, I would say. On the other angle is the power of digital. In many countries, my own included, we are seeing pharmacists, nurses, doctors, doing a whole bunch of work which is not theirs to do, administrative work, wasting time of highly valuable resources doing things that they shouldn't be doing. So that's where I believe the power of digital, of the digital transformation can actually help us. And we are part of the European Union. There's millions of euros available for digital transformation. I am seeing that money being spent on computers, on updating infrastructure. Of course, it's important. But we're wasting an opportunity because we are transforming what is analogic, what we already do in the analogic world, into the digital, but keeping the process the same. We should be using the digital revolution to actually take us to the next level so that we can task shift to machines the work we don't want our healthcare professionals to do, so we actually don't need so many healthcare workers to take care of the patients at the end of the day. And so I would say it's working in these two fronts, on governance, policy, and on the other hand, using the power of technology, that we will be able to address the challenge in the future. But at the end of the day, I have to say this. The most efficient hospitals are the ones that have no patients. right? And there's this episode, do you know this TV series called Yes, Minister? Yeah, so it's a British sitcom. And so the Minister of Health was told that the most efficient hospital in London just won an award of the most hygienic hospital in London. And he said, I have to see this. As a politician, of course, he wanted to take the media with him, so he went to the hospital. When he got there, he visited the hospital, and when he was in the operating room, he turned to the president of the board of the hospital and said, where are the patients? I haven't seen patients yet. And she says, oh, we haven't opened to the patients yet. And he said, why are you working? Oh, we have 500 people that we have on salary. We can't close. And then he said, well, I'm closing it until you open to patients. And the union person came, then we're going on strike. And he said, then go on strike. It just goes on and on. But at the end of the day, what I'm saying is, if you're able to lower the burden of disease, the less patients you need using hospitals, the more resources you'll make free to treat those that need it, the more efficient we will be. The problem is, since we have failed redundantly and seen so many people sick that shouldn't be sick with multimorbidities, having to use our health systems across the board, well, then there are not enough resources to go around and not enough healthcare workers also to respond. So I'd say those are the 3 pillars to try to respond to your difficult question.
Thank you. Do we have another question? Maybe the last one right now. Do we have one? Yes, we have one question.
Yeah, I'm sorry, but I'm very skeptical about your solutions. You have done quite a good diagnostic presentation, but I'm afraid that digitalization is far from the optimal solution. Okay, it can help to the healthcare system, but to see the technology as the treatment of the healthcare systems, I believe it's quite wrong. I mean, it's impossible to go into the details, but I'm afraid that this is not a solution for any healthcare system.
Do we have a question? No.
Actually,
okay, thank you.
Actually not. Just this skepticism that technology won't help. Similar as for ecology and all global problems.
Thank you.
So may I ask?
Yes, of course.
So what would you consider the main priority for transformation of health systems to make them sustainable and resilient in the future?
Yeah, it's the problem that the capital is now leading the whole world, so that we should start, as you showed us many years ago, and to try to go into the other direction, to more humanistic approaches, which is, it seems absurd at these times where capital is leading everything, but I'm afraid that this is not a solution.
Yeah. Well, I take your comment, and I understand it, and I acknowledge that there are risks, and I acknowledge that it's not the sole solution. But as I mentioned before, digital is a tool that we can use to address the underlying challenge, which is how do we get to the 60% of what actually influences our health? How do we actually address the issues of behaviors? How do we actually address the issues of where we work, the environment in which we live in? And to address that, for 70 years, my public health colleagues have been calling on us to address many of these challenges through public health approach. Over the last 30 years, we've been talking about social determinants of health. And the reason I believe none of this has worked, although scientifically sound, is because it is not part of the governance structure of health. The way the budgets are built, the way the governance model is built, is all driven by disease. What happens in most countries is you have 99% of your resources being spent on treating diseases, and 1% in the public health institute, wherever, that actually do health literacy and do some health promotions. And that is a broken system that does not work. What I am proposing here is a transformation in which we start measuring results at the community level. If we actually start doing that, we can pinpoint geographically where our problems are. As a deputy mayor in my city many years ago, I started georeferencing health data. And I started to see, for example, childhood obesity prevalence and adult obesity prevalence. And that allowed me to cross that data with poverty data, with social data. And with that, I was able to start building bike lanes exactly there. I was able to build up community-based programs to address metabolic disease in that region and to work with schools and other institutions towards prevention programs and to measure results as we went down the road. Was data the thing that transformed it? No. Data enabled the transformation. It's an enabler. It's available to all of us, and it makes it transparent, it makes it available for everyone to see, and it keeps politicians accountable. It keeps governments accountable, it keeps public health officials accountable on what they're doing. Not measuring is bad politics. Not measuring results is bad governance. And we are paying the result with these unsustainable health systems, with the rise of costs and the rise of disease, getting our people healthy. Instead of getting them healthier, they're getting sicker. And as we see age going forward and people getting older, what we're seeing is that those that actually have less resources, the poorest of the poor, are the ones that are going to pay the price. And so I think we are agreeing that we need to fix the human aspect of healthcare systems. What I advocate is that the technologies that are accessible to us today should be used precisely to help us accelerate and be more transparent.
Thank you very much.
Thank you.
Thank you. We'll stay with the data and we'll leave some room for Eric. So I'll continue in Slovene. Zdravstvenih podatkov je veliko.
Now, the volume of health data is abundant, it is expanding, it is of paramount importance, of course, but to what extent is health data being used wisely when it comes to personalized medicine, that is, healthcare tailored to the individual patient, an approach where data would be more accessible and constantly outdated would provide the doctor with high-quality support in deciding about the best possible treatment for the individual patient. High-quality and accessible health data is also essential for optimizing the health system, for the functioning of institutions, for research and development, both in diagnostics and in the development and introduction of new treatments. The title of the next presentation will be "A Data-Driven Healthcare System Will Be Resilient and Future-Ready." It will be presented by the leader of digital health at the OECD, Mr. Eric Sutherland.
Healthcare system will be resilient and future-ready. Eric Sutherland.
So thank you very much. I am like my colleague that my first time in Slovenia. This is actually my first time on a stage for the last 3 years. So it's actually quite odd. Thank you. It has been a very odd several years for all of us, I know. But I come to you today from the Organization for Economic Cooperation and Development, otherwise known as the OECD. I thank Ricardo for presenting such fantastic slides about the OECD because it meant that I don't have to. My intention today, and actually the order of presentations was fantastic, because we really started laying out why we were doing this, what we need to be worrying about, and what I'm hoping to provide today are some ideas about the how we can actually move forward with some of these areas in and of itself. Let's see if this works. My role of the OECD, I've only been there for 6 months, and I come there by way of Canada. I apologize for speaking too quickly. It is the nature of being a Canadian, and apologizing is also the nature of being Canadian. So I'm sorry for anything bad that happens to any of you over the span of the day. In terms of our system itself, and I could have used electricity as my analogy for data. I choose to use the analogy of water. And I use water because it allows me to paint a picture of our fragmented systems of water captured in silos that are housed to actually do things within specific facilities and specific systems. And we've built and incented this system to be built up over the span of the last 60 years. And when we need to ask questions of these series of silos, we need to build scaffolding to connect those silos together, to connect information to be able to answer those questions. And then we maintain that scaffolding. Sometimes we have to build a new silo. And sure, some of the stuff in there is the same as the stuff that's over here, but we want it quickly. So we're going to build a new silo as opposed to creating new information in of itself. And so what we've created is this rickety collection of scaffolding connecting old silos that aren't working together, are hard to answer new questions, can't actually respond to the needs that we have. And what we can do with them fantastically is we can create great reports about the effectiveness of our health systems 3 years after the fact. Not particularly useful. There are literally organizations that are creating reports about how systems are performing in 2019 today. The system that we have in 2023 is fundamentally different than the world we lived in 2019. So we need to be thinking about how we can be adapting our systems and evolving our systems to be able to respond to the questions that we have much more quickly and effectively. But it really is all about the questions. Riffing on where Boye was going and frankly where Ricardo was going in terms of the metrics and what is the performance of our system, it's fundamentally a question. So we need to be more focused on what are the questions we need to be trying to answer and how we can design our systems to be able to answer those questions. And yes, I would submit that much of that is related to the data infrastructure, the ability to connect that data back and forth, but we need to be able to connect that data. So we need the water, the data, and we need the pipes that actually carry the data back and forth. Those are a lot of the digital technologies and tools, the interoperability that allow things to work together. And we also need taps that allow us to extract the data and the insights out of the systems in and of itself to actually have an effective system working together. And what happens when you have pipes and taps without water? You get a whole lot of hot air. Politicians. So, sorry. What happens when you have pipes and water with no taps? You get a lot of pressure in the system that's going to burst. And what happens when you have water and taps with no pipes? You get mud. That's not particularly useful. So what we need is to have a coherent approach across the pipes, the technologies, the water, the data, the taps, the analytics, that actually brings all this stuff together. But what we've done historically is we've actually designed those three areas idiosyncratically, not really understanding how they need to work together. And the result is we've created this monstrous mess of disconnected technologies that are not able to respond when we need them. We need to be redesigning our systems around this integrated approach from around analytics and digital and technology, I say, and data. And when we do that, then we can actually get somewhere. But importantly, I do not blame the technologists. The technologists that have actually designed the fragmented technologies, because they did exactly what they were incented to do. The problems that we have is that the policies and the incentive structures are fragmented in and of themselves. And so what we really need to be thinking about is what are the policies that are designed to achieve the end product that we want. So with that, I'm going to move a bit faster. And so I reflect on other industries have learned this. We can do pretty much whatever we want on our cell phones, except healthcare. We might be able to, you guys are lucky in Slovenia. I saw the Slovenian app earlier on today. It's fantastic in terms of your ability to get access. I wish I had that in Canada. For me to get information to my health data in Canada, I need to go to 96 different portals in order to get a comprehensive health record for myself. What? That doesn't make any sense. But these other industries have learned that by connecting their data, they can provide better customer experience, create better choice, and create the experience that the customers want in order to achieve their better outcomes. They designed their solutions around the outcomes that they wanted while achieving and staying true to their ethical things. The analogy is obviously no one would want to fly an airplane that was designed by the health system. And if you think of that, does that really give you comfort? But is that true? Think about that as we go through. When we think about health, and Ricardo touched on this, a bit of this, we need to remember why we're doing this, and a lot of this is around ensuring that we are designing around the patient, around the person. I prefer to talk about the person because a patient is, in an episode of care, whereas theoretically we are all patients throughout our entire lives, from cradle to grave. But talking about person-centeredness is really, really important, and I totally agree about how it is pervasive across the system, not just an afterthought at the end. It's how they are embedded into absolutely everything. And we need to be really measuring what the outcomes are, but as well as their experience and the provider experience in themselves. We can't forget about them. And we have to manage it within a cost base and ensure that equities are actually addressed. Collectively, this is known as quintuple aim, and we need to remember that as we're evolving these words and we're measuring our outcomes, which is absolutely important, we need to be measuring it, and that provides a framework for how we can actually measure things to not to ensure that we are addressing all aspects of it, that we're not creating fantastic patient experience at the cost of burning out our doctors. That cannot be a viable outcome, and frankly, something we've experienced the last couple of years. I got my animations. So one of the things that we need to do is we need to be question-centric. We need to start with the questions. What do we want to improve? How do we actually design the analytics to actually answer that question of itself? What data can we actually gather in order to actually answer that question? What data do we need? Do we have? What can we reuse? What new data do we require? Then we worry about the technology, the design. How do we connect the systems together and actually think about all of this work? We align the human factors, and I'll talk a little bit more about that later on, but the human factors are so essential because all of this work happens because we're able to get the private sector, the public sector, the doctors, the nurses, and the patients, and all parts of the society to work together toward a common goal and objective. Whereas individual organizations trying to optimize for themselves can actually create a disastrous outcome for the whole. Again, I'll touch on that a little later on. And after we've done all this, then we can go from the point of, okay, we've collected data we've gone to the people, they have an experience, we have their data. We take the data, we turn it into information, the information turns into insight, and then the insight turns into action. And when we do that over and over and over again, but actively reusing the things that we've already done, we can start to think about the system as this ecosystem. We can start to answer new questions, or rather, we understand what questions we can answer, and when we're asked a new question, we can see, given the set of data assets we already have, can I already answer that question inherently? What is the small incremental thing I need in order to answer that new question? And that is really where I think we need to be going, is how can we leverage the myriad of data assets we already have in order to be able to advance our overall work together? So that led me to the concept of this integrated digital health ecosystem. And not surprisingly, as I was talking about before, it recognizes that we have to be worrying about the analytics that we have in the system. And yes, that includes AI. I'll touch on that a little bit later on. But it's not just the analytics from the perspective of primary care. There is primary care absolutely is the bedrock of the system. But too often in conversations, I have heard no acknowledgement of secondary uses of data around research, around analytics, around innovation, around health system performance, around measuring the effectiveness of our systems. We need to be designing our data collection, our analytic processes that allows for both the primary uses of data as well as the secondary uses of data. And goodness knows, in the last couple of years, we learned of the importance of those secondary uses of data through our experiences of COVID-19. And all of those areas of primary and secondary use are connected through this integrated health data, the ability to take what data we have, link it together, and use it more effectively. I use the term health data here loosely because, per what we've heard from both of the previous talks, the data that we require in order to answer some of these questions often will come outside of the traditional health system. It will come from the social factors. It will come from education, from social programs, et cetera. And all of these things need to come together to help us answer the questions. All of that needs to be wrapped in a layer, which I've framed as the blue, of ensuring the right security protections, the right digital protections, and the right interfaces are in place to make it easy and intuitive to use the platforms that we have. But then perhaps most important is the outermost layer, because this is where the human factors come in, that we have enough capacity in the system to do the job. We know we're facing workforce crisis across the world. But one of the interesting questions I would submit is, what if we were to activate people as health workers? What can we do? Which is not to say that we're going to fully rely upon them. Lord, that would not be the right thing to do. But there are some things that we can do in order to help people have agency in their own care. And what can we actually do in order to realize is the ultimate outcome? But a big part of that, and I don't know if you've had this experience, you can get, here's my discharge abstract, and you suddenly look at this thing that comes from after you've been released from hospital, and you can't understand any of it. It has a single word in there, carcinoma. My God, what the hell happened? And suddenly I'm talking to 50,000 people to work out what happened to me. And then when you interpret what it actually means, oh, it actually means that it's a low risk situation. It's totally fine. But a person doesn't know that because they look at the word carcinoma, cancer, oh bad, I'm going to go off and panic. So we need to, at the same time as we're doing all this, to improve the health literacy amongst the public in order to improve their ability to use these new tools and technologies that we're doing. We need to better empower providers because they have been used to, for many years, communicating only with other providers. So their communication, the language that they use, is actually foreign to the language that we would use as the public. So how can we bridge that divide to actually ensure that the right people are getting the right data and information at the right time in a way that they can actually meaningfully use it? And too often, I think we push information out, and we hope that something good happens, and then, frankly, disasters happen. And when disasters happen, the bad news is that it's not that you were back at zero. You're now back at negative. So you've got to actually overcome the barrier, the problems that you created for yourself, and then actually implement the solutions. I look at what happened with some of the early interventions in artificial intelligence around radiology, and in the scan they said, oh, we've detected cancers. But what they actually detected was a ruler in the image. So there was actually not an effective use of AI. It's gotten far better than that now. It actually does it reasonably well. But that's the story that people will remember from 15 years ago. Because, oh, well, I couldn't trust AI then, so why should I trust AI now? Because it's 15 years further on. The world has changed. But reminding people that things are fundamentally different. None of us had cell phones in our pockets 15 years ago. Well, maybe not none of us, but many, certainly not to the same prevalence that we have today. The world has changed. And the way that, from a health perspective, we need to be designing ourselves to be adaptable to that change. But we're also afraid of the risks. And because we're afraid of the risks, it creates this impediment that we have to make changes at the type of pace that, frankly, we have the opportunity to and potentially could demand. And I'll touch on that a bit more in a second. One of the things, and I'll touch on this briefly, is the idea of a learning health system, which is really that upper line that Ricardo showed earlier on, where every encounter in a health system is actually improving the effectiveness of the health system, both for me and my communities and for society as a whole. And that's ultimately where we want to go. And when we do this, when we create our pipes and water and taps in an effective way, it frankly will be far more cost effective because we're reusing the things that we've already done. We're reusing the investments we've already made. So many of the investments in healthcare, frankly, do not achieve their desired financial outcomes because they are not reused in the way that they were intended to. Or if they do, it's because the costs of actually maintaining those solutions are not properly considered in and of itself. So we really need to be thinking about, in this system, why is it more cost effective? How is it more scalable? And how are we able to answer the new questions that we need to on a regular basis? And what possibly most important of all this is that it is responsive to change, because we need the ability to answer questions quickly when we need to. We had that at the beginning of COVID, and we need to have systems that are designed to be adaptable to that change. Sadly, in a system of fragmented silos, it is actually, if anything, it is the opposite of responsive. It is more concrete than anything else. And so, reflecting what we heard earlier on, what is important, and I love Boy's quote earlier on, action without vision is a nightmare. And so it is really important to ensure that as we are going into digitalization, that we're doing it in the context of where we want to go. We are not simply going to say, okay, let's take this old process and actually just create forms and digitize it, and then hey, we've digitized things. We need to re-rationalize the processes given how things are operating today. And one of the examples I will give of that is this. In one of my prior jobs, we asked, how long does it take an innovator to get access to an asset? They wanted to get access, they had consent for the patient. How can I get access to that lab data, as it turned out, in one of the provinces of Canada? And we did the process map. 18 months was the answer for one innovator to get access to one system for one patient. Not sustainable, not effective. But what this is the combination of 5 organizations coming together, each designing their own idiosyncratic privacy processes, and saying, well, we have our privacy process, so we have to follow these guidelines, and I can't trust anybody else's processes. So we have to do our own full assessment, and the amount of passing back and forth that happened ended up in this process that, frankly, forgot about the patient. I forgot about why we are doing this. This is digitizing a process. This is not creating the process that we actually need. So from that perspective, this is not about the digital and the technologies being the solution. This is about reflecting what we heard earlier on. It is about it being an enabler of the solution, but it is the human factors that will actually ensure that we use the technologies most effectively, centered on the outcomes that we want to overall achieve. And there are a number of blockers that we have. I talked about this earlier on this year. Really, where a lot of the barriers to achieving our digital future have nothing to do with technology. The most significant barriers to achieving the digital outcomes that we want is actually the people that are involved in the design and operation of our systems. So if I can leave you with one last thought. As much as we talk about digital health, and it is often associated heavily with technology as what digital health is, I would submit to you that digital health is, in fact, the most human of all disciplines. It must be the most human of all disciplines in order to ensure that as we're developing these new tools and technology, that we are keeping our people, the humans, in the loop and at the center and all over the whole solution in order to achieve our overall outcomes in and of itself. Yeah.
Thank you. This was very interesting, especially about after the most rainy May in Slovenia, in probably the history of Slovenia, talking about water and pipelines.
They've had a few floods in the... Yeah.
Some questions before the coffee break?
Oh, I was between people and... Oh, that's bad. It's not a good place to be.
Do we have a question? Or maybe you can ask Eric something during the...
I have a question
Petra,
or a comment. You mentioned the importance of health literacy. And I think that's important. However, as a patient, as a user of health services, when I hear that, health literacy, I kind of feel that I'm expected as a patient to start learning about medicine and all the complex terminology that they're using. And I'm thankful to the internet because I Googled all the complex expressions. However, what I, as a patient, am expecting, of course, is a different kind of communication with me in an understandable language. And I think also digitalization that you talk about can be a helpful tool in that respect as well, because that's the big issue for us patients, understanding all the data that's available about us.
Yeah, what I would say there is, like, historically, doctors, as I said, they're used to talking to doctors through these notes. And so they write in a language that is appropriate for doctors to talk to doctors, which is certainly at a very high university grade level. Whereas when I want to consume it, I certainly haven't had that experience. I want the terminology, now that I have access to it, to be presented to me in a way that I can actually consume. Some of that is going to be training for the doctors. Some of that is learning for ourselves, but this is actually where, and I think this may be an innovative use of things like artificial intelligence, to actually say, how can you take the complex jargon that is used by doctors to communicate and simplify the language for me? Don't change the meaning of it, but actually just write it in a way that I can more easily understand it, given my own inherent knowledge. I think that's an interesting area. I understand there are some countries and some companies that are working on those types of solutions right now. I think that's actually a real opportunity for innovation in order to bridge the gap, because in a world where we want to give patients more agency, that agency isn't going to be possible without bridging that communication gap. And is unreasonable to expect 7 billion people or 8 billion people to actually suddenly all become medical grade communicators. And so how can we actually use technologies in order to lower the requirements to entry to understand what's going on, or even just to say, here are the things that you probably are most curious about, where you should contact your medical provider. Even that as a conversation, a prompt for me, would actually be helpful in of itself. So I think that's, in the context of future of health and innovation, that's an interesting innovation.
At this moment, some patients look for medical advices on Facebook.
Yes.
Because they can't read, they can't understand what the doctor was...
That is not unique to here. That is absolutely everywhere. I will say that the number of times, as much as I've only been with the OECD a short time, the number of times that I talk to a country and say, well, here, this is how things are, I try to comfort them saying, you're not alone. Because a lot of the problems that countries have are shared around the world, which goes back to what we heard earlier on. 80% of problems are common. And that is absolutely true. But there are big opportunities for common solutions to common problems.
Also, yes. Thank you. Eric, do we have a question? A second one?
They want coffee.
Coffee. We all need coffee. Thank you, Eric. Thank you. Welcome in Slovenia. Pol ure za
Now, we have a half an hour break for coffee and refreshments. We can tackle any challenge with a good coffee. So I wish you a good, strong coffee and see you back in half an hour so that we will be cracking other nuts.
Čez pol ure se srečamo nazaj.
The results of medical innovation are not just charts, numbers, and statistics. The results are real lives of real people transformed. Because it's there in black and white. They are doing what they never thought possible. Living longer, better, fuller lives. Overcoming conditions in ways that were once impossible. And we won't rest until patients everywhere can see the results in black and white. The results of medical innovation are not just charts, numbers, and statistics. The results are real lives of real people transformed. Because it's there in black and white. They are doing what they never thought possible. Living longer, better, fuller lives. Overcoming conditions in ways that were once impossible. And we won't rest until patients everywhere can see the results in black and white. The results of medical innovation are not just charts, numbers, and statistics. The results are real lives of real people transformed. Because it's there in black and white. They are doing what they never thought possible. Living longer, better, fuller lives. Overcoming conditions in ways that were once impossible. And we won't rest until patients everywhere can see the results in black and white. The results of medical innovation are not just charts, numbers, and statistics. The results are real lives of real people transformed.
Smo se posvetili pogledom svetovnih strokovnjakov in njihovim izkušnjam ter praksah v drugih državah sveta. Najbolj pa nas zanima, kako je doma in kako slovensko zdravstvo pripraviti na izzive, ki so že z nami, so blizu in še pridejo.
And how we can tackle the challenges that we will be facing in the future. We've also discussed recently how the system could be strengthened from various disruptions in the supply chains, in the healthcare system, everything that we've experienced just recently. How do we prepare our system on unexpected, unpredicted events? We will now be inviting the following guest to the panel, Mr. Dorian Marušič, a former health minister and the medical director of the Isola Hospital. He has participated in a number of international and national projects regarding healthcare and health insurance systems, payments, improving of national and international systems of cost accounting. At the moment, he is a lecturer at the Primorska University. He also has a daughter with the most beautiful name in the world, Martina, just as my name is. I would also like to invite Mrs. Metka Zaletel from the National Institute of Public Health. For more than 10 years, he has been a head of the Health Data Center. During her leadership, the National Institute of Public Health has become a leading institution in the area of health service. She's active in many international events regarding data and information. She has participated in designing common measures of the European Union, and her work has contributed to the exchange of health information between countries, the opening up of data. At the moment, she's focusing on the establishment of a national network for health information. Mrs. Zaletel, welcome. Mirsha Poldrugovac is an expert of public health, working at the Center for Healthcare at the National Institute of Public Health. He's dealing with the performance assessment of healthcare system and evidence-based decision-making. In the past, he worked as an advisor at the Ministry of Health, focusing on quality and security and safety. He is participating in a PhD study in Amsterdam. Welcome. Simon Rekanovic, a resident in radiology. Welcome. An innovator and entrepreneur as well. His focus is medical data, its organization and analysis. He's also the director and establishment of the Illyrius Institute, focusing on digitization in healthcare. He participates in a number of Slovenian and international projects regarding the transformation of healthcare and organization in health. Recently, he has been focusing on improving standardized storage of medical data and the ways of using artificial intelligence in order to decrease administrative burden and improving patient-centered healthcare. I have talked to Simon online, and I knew at that time that I would be seeing him in person too. So welcome.
I am
also inviting Dr. Tanja Španić, an advocate of patients, the president of the Association Europa Donna Slovenia, and president of the European Association for Breast Cancer, Europa Donna. Tanja is a wonderful person. She developed at the age of 26 the breast cancer, and only 1 year later she joined the association, which she is now chairing. She's also a mother, which is one of her most important roles. She works with the ESMO Association and is a member of the organizational committee of several trials and a member of the advisory committee and a committee at the Oncology Institute. I did this very, very quickly because I want to leave as much time as possible for the round table. The round table will be headed by Dr. Petra Došenović-Bonča, an associate professor and the head of the Department of Economics at the Faculty of Economics in Ljubljana. She focuses on the economics of the public sector and the health system. She's also a member of the Operational Research Society research organization. She has published a number of papers focusing on various aspects of the Slovenian health system as well as health reform. She also also participates in advisory projects in healthcare in Slovenia at the Faculty of Economics. She has been very active in developing the masters regarding healthcare economics and organization. She is a lecturer in various subjects connected with that masters. Mrs. Dušenović-Bonča and Mr. Marušič will be co-chairing this roundtable discussion. Thank you very much for inviting us to this event and also for inviting me as a chair of this roundtable. The purpose of our panel is to talk about how we see a future-proof healthcare. We expect our healthcare system to address patient needs as much as possible. And I will start with Tanya sitting to my left. We have heard today mentioned a number of times that patients need patient-centered, patient-focused, personalized healthcare and medicine. This is one thing. The other thing is that healthcare professionals too need responsible, empowered and aware patients. So partnership is the key word here. I have mentioned many catchphrases now, many of the most popular words we are hearing on a daily basis today. How do you think we should support both patients as well as experts, that is, healthcare professionals, in order to improve this partnership? Thank you very much for the floor. Thank you for inviting me. As you have mentioned, these words that you've now spoken out are around all the time. But they become a reality when you become a patient, when you develop a chronic disease, for instance. Very often, at that point, we are no longer a person, we are a diagnosis, we are a code for that diagnosis, and you are constantly followed by that diagnosis. Everyone is focusing on the diagnosis, not on the person. As regards personalized healthcare, personalized medicine, how is personalized medicine about to be performed? Firstly, by understanding the patient in a holistic manner, the patient as a whole. We are moving up to that target. It's not that we are not. We do have some examples of good practice in Slovenia. The biggest development, I think, is noticeable in rare diseases or rare cancers. But after an acute initial phase of treatment, when a person should be reintegrated in society, now that phase is just as important. Currently, we have been discussing personalized medicine for, I think, more than 10 years. I agree with one of the lecturers. We do not need to reinvent the wheel. So what we are missing here is we are aware of what is needed, but there is no action. And we should get this action going. We need to do this on a step-by-step basis based on what we are having in our hands now. We patients, of course, are users of the healthcare systems. And it is only when you get ill, it is only when you develop a disease that you understand how important the healthcare system is. And we must educate our children from the very beginning that prevention is so very important. We are working partly on prevention, for instance, on prevention of non-contagious chronic diseases, but I don't think people in general are really aware how important that aspect is, prevention. Thank you very much. Now, today we discussed a lot the digital transformation, digitization as possibly an important and useful tool. It seems, however, that those who are most vulnerable today, that is the elderly, will find it most difficult to use the most valuable tools of tomorrow, that is digital tools. Yes, I agree, and I can share with you an experience we gained just yesterday. As a patients' organization, we provide counseling, including counseling over the phone. And just yesterday, a 73-year-old lady came by and she said she would like to have that app installed on her mobile phone because she would like to have access to her healthcare charts and documents. And a colleague of mine helped her download the app, do this electronic signature. We did this, my colleague and myself, because we thought that we would be able to do this. We did this by calling in another expert, another assistant, and we spend, I think, more than half an hour on doing this simple task. I'm different. I'm not 73 years old. I grew up by using the telephone. I can lose anything, just not my phone. And still, I am not competent enough. So how are we going to train this population to be able to use digital tools? Perhaps they do not need training at all. Perhaps what they need is proper support, proper assistance. Yes, I agree, and you need to take into account the needs of this special group of patients. Now, Mr. Eliasson asked the question as to what do we want, a better healthcare system or a healthier population? I think that both aspects need to be addressed. What do you think? What do you think is the role of patients in terms of their responsibility and accountability? Well, I cannot but agree that we ourselves can do the utmost and the most for our health, unless we have some genetic diseases which we could, of course, not have prevented. But we are responsible for our own health by using vaccination programs, screening programs, and so on, in order to not need medical therapies later on. Of course, preventive actions are better for anyone. We do not need all the beautiful buzzwords here. We need to go to the grassroots levels. We need to start listening to the people in oncology. High-quality life means much more to patients than a long life, be it whatever form it may take. So these are the very basic questions that we must ask ourselves. First, we must ask the right questions in order to be able to provide the right answers. Now, thank you very much. That was very nice to hear. You mentioned also that by not investing sufficiently in prevention, losses occur in other parts of the health system. There is a whole lot of studies showing that more than 20% of spending is unnecessary, is wasteful. The same goes for healthcare sessions and interventions. If some issues were resolved at an earlier stage or prevented, health or medical interventions would not be needed. Dr. Marušić, how would you prevent wasteful spending of resources? And I think that happens in every country. How would you address the issue of excessive wasteful spending? Well, thank you very much for this question. And first of all, I would like to sincerely thank the organizational team of this conference for the selection of top quality lecturer panelists. I always thought I'm a utopist, I'm an idealist, I today realize. I have heard about many different healthcare systems, but less than 5 times today I heard the terms mentioned such as hospital, healthcare centers. I heard about the processes and about results. Now the 20% of wasteful spending, of course, we should cut the wasteful spending, but how do we do this? In order to do a breakthrough mindset change, firstly, we must need to talk to each other. Today we've listened that what is needed is investment in healthcare, not just spending in healthcare. So the main and the primary goal, first of all, should be how to decrease the difference between the healthy years of life and the expected lifespan. If this really was our main goal, then our hospitals would probably be empty. We would finance them, of course, but then we would have GP practices with 5, 6 sick persons, but that, I guess, is utopia. But first of all, we need to change the terminology that we are using. Secondly, we must change our focus from cure to prevention. We must change our approach to work, remuneration, incentives, in order to be able to measure results from the patient's perspective and from the provider's perspective. So we need to measure results. I was happy to see a slide in the PowerPoint presentation about the prostate cancer. We have been showing the same or a similar picture in Slovenia for years. What we saw on that slide is what should be our goal. And slides of that type should be shown to women in order to send their men to the right institution for surgery. We need to start setting up a system in a new environment with a new paradigm by monitoring and measuring the process and the outcomes, and this should then become the main criteria in reorganizing our health system. All the other forecasts, such as the demographic shock, the pyramid turned around, and new technologies and their impact. If we look into the real world, it becomes quite simple. A certain share of the GDP will be allocated to health and to the healthcare. But the question is, by doing so, do we really achieve a society that will be healthier? The 70 million euros that were allocated to what we call a shock therapy, was that wasteful spending? The fact is that the real results will be seen in a year, 2, 3 years. If the health of Slovenians improves within that time span, then of course the investment was not wasted, especially in terms of better sight, because from what I know, out of the 70 million, the best providers to spend this money were those offering ophthalmological services. Thank you very much. You are also a part of the group that was preparing guidelines on value-based healthcare in Slovenia. Today, I heard quite a number of new pieces of information. Today, we've discussed patient-relevant outcomes with PROMs and PREMs. But what I missed in that discussion, and that was also highlighted today, were the so-called community-based outcome measures. So it's not just patient-based, but also community-based outcome measures. Yes, thank you. Now, in the VBHC guidelines, and also in other documents. It is clear that what you mentioned, the community-based outcome measurements will be difficult to achieve, although there could be a possibility in Slovenia because of our organization at the local levels, at the municipal levels. We have mayors who are not really aware of the importance of these outcome measurements. They are able to discuss building a new healthcare center or providing education and training regarding preventive healthcare at schools. So the results as regards outcome measurements at the local level are rather modest at the moment. Thank you very much. Mrs. Letel, Dr. Marušič mentioned that in the future process indicators, including result indicators, will gain on importance. You work with data at the Public Health Institute. Now, we individuals sometimes think that we are afloat in data. We are lost in the abundance of various data. Is it the problem in the fact that we are not able to properly use data, and how can data help decision makers? Eric today said that we have a system enabling us to realize, say, in 3 years how well we did. For future-proof healthcare systems, 3 years is too late. We need data at this very moment, immediately. So how would you, by collecting and providing data, support decision makers? Thank you very much. I too would first of all like to thank you for organizing this conference and for inviting me to the round table. Now, the fact is that Slovenia has, and it did have in the past, volumes of data. The National Institute of Public Health is this year celebrating its 100 years anniversary. And on its website, the Institute shows what sources of information it uses. And we can see there that the prevalence and incidence rates of diseases are very well covered with data, but there are still some gaps. It is clear from our discussion today that we have a number of, well, I would call them information peaks, mountains that we have not conquered yet. PREMS, patient-reported experience measures, are indicators collected by the Institute of Public Health since 2019, both at the hospital levels and specialty levels. We are not as far as to be able to provide these data in a meaningful way at the national level. Healthcare providers, however, are happy to have them. As regards the community-based outcomes, I should mention a project of our institute, Health in Municipalities. This is a project started off in 2016, and part of the project, Health in Municipalities, is a project called the Golden Stone. Within this project, we are cooperating with mayors, trying to tell them and convince them that it's not only roads and schools that are important in their municipalities, but that health in municipalities is important too. When we, at one occasion, visited what we call Municipality of Health, because this is an award that we are granting on a yearly basis, we do a snapshot of what a recognized Municipality of Health did better benchmark to other municipalities in Slovenia. And we are trying to improve our work on a regular basis. Several important layers are worth mentioning here. One layer, for instance, is showing how decision makers are using the data that we make available. A couple of years ago, measures, actions were adopted without the necessary data. Of course, I'm not speaking about the current minister, or, for instance, decision makers used to apply data, but without the necessary sophistication. We are finding today that based on the data we have available, we must build models taking into account a much more sophisticated analysis than just simple tables or Excel sheets. The next thing that I would like to mention is the idea of literacy. I'm not just speaking about health literacy. It's difficult to say what types of literacy in all fronts we need. Most surely we need what I would call a statistics literacy, that is the skill of understanding statistical data. Ministers, of course, can be given volumes and volumes of data, but how to make sense of them is a matter of statistics literacy. Thank you very much. Now, with indicators, it is very important to understand what an indicator is telling us. If I say in Slovenia we spend 9.2% of our GDP for healthcare, this is not enough. This is just a piece of irrelevant information. We need it benchmarked not only with healthcare providers in Slovenia, but also with other countries in Europe and worldwide. What potential do you see in data, including indicators for decision makers and also for specific healthcare providers? Now, the European health data space is being created. I hope that the necessary legal basis will be adopted this year. It brings two important ideas. Firstly, the primary use of data, and secondly, the secondary use of data. The primary use of data. Now, here Slovenia is very advanced. We have the central register, for instance, and the EHDS will make it more standardized and comparable to other countries. Cross-border exchange of summary of patient data, that is what we are striving for. Now, the second dimension, secondary use, is also quite spread in Slovenia, at least among experts. It will help Slovenian experts and professionals access data arising from other countries. And again, here comparability is of key importance. We have a number of institutions that are regularly collecting health data without publishing them or releasing them. So any researcher must be able to understand who they should contact, and the European health data space will bring
Zelo veliko smo danes govorili o tem, kako podatki, ki jih pretvorimo v smiselne informacije, koristijo odločevalce.
Transformed into meaningful information can help decision makers. Decision makers can be either the payers, or the Ministry of Health, or whatever. In the case of Portugal, we saw today that data as a feedback for healthcare professionals brings important advantages and benefits. Also, incentives are significant here. Dr. Arkanovic, you represent a healthcare provider here. You are one of those who are possessing, collecting, and transferring large volumes of data to other institutions. How frustrated are you by receiving or not receiving feedback? We heard today the slogan, data for better life, and sometimes the data we get do not make our lives better, they make it harder. What do you think about digital solutions? Could you pinpoint any specific digital solution that made your life and professional life with patients easier? No, thank you very much, first of all, for inviting me. Well, not that I particularly wanted to speak here, but somehow no one else in my organization was not willing to, so they said, you are the best to represent. As regards data and the uniform data formats, first of all, I would like to break a myth. Individuals and healthcare professionals, there is a belief that they do not really like digital tools. I'm not sure that this is true. I think that we are all able to use smartphones, touch phones, with some exceptions. For instance, my father is more than 80 years old and he has some issues with his smartphone, but he's excellent in using Facebook, for example. So in terms of being able to use digital technologies, I don't think we are doing really bad. There are other technologies, though, where we are not good enough because we have not learned it. So if we look at the nature of using digital tools and data, there is an issue because the format of data is not uniform. I have been an active doctor for 5 years, and I can tell you that tiny things can do enormous changes. A tiny novelty may be a new app or a new field in a certain app. For instance, just last weekend I worked at the emergency ward, and the more data I get from a person who is in an emergency situation, the better I can help them. And if I need some time to access the central register of patients, to access another app, I lose moments of time, and that may be key. And a tiny novelty, during my last emergency ward session, was that I did not have to ask for an authorization to access the register. It seems a very tiny thing, like a few seconds, but for me it was a great advantage because one step was deleted and I didn't have to do it again. So as I said, tiny steps, tiny novelties can have a tremendous impact. As regards new solutions, as a radiologist, I can say that many people cannot imagine how important for me when I read an image is to have a time lapse. For instance, an image of a carcinome and compare it to another image from 3 weeks ago. In order to access older images, I have to leave one app and enter another app. I need to have them all together. So again, these would be tiny reforms, tiny changes, far away from artificial intelligence, but they can make great impact for me as a healthcare professional and for the patient too. And if I have very little time, I will not compare the current image that I am reading with the image taken 3 or 4 weeks ago. If I need to make many clicks on my computer to enter other storage areas in the system, I will sometimes not do them. And of course, this is not good. Thank you very much. Digital competencies are important today in the current IT environment. So you say that we have digital competencies, but sometimes it is just this mistrust and the fear on the part of healthcare professionals, and they just automatically refuse new technologies. Maybe I can go on with Mr. Paul Drugovac. One of the barriers that we are noticing is the fear of change, the mistrust as to what change is going to bring. How would you evaluate the level of collaborative organizational culture in healthcare? Do we in our healthcare system have the fear of change? Does this has to do with the high level of hierarchy still existing in the healthcare system in Slovenia? And how could we prevent excessive fear from developing new tools, methods, and digital competences? Thank you very much. Now, I would first of all touch upon the word mistrust, because mistrust, I think, is a key term in this discussion. I think it does exist, this mistrust, as it does in many other environments. Mistrust and resistance to change. It is only natural to have it. I have worked at the Ministry of Health and also at the Public Health Institute, and in this career of mine, I did not get the feeling that the basic barrier to not use big data is mistrust. When data was available, when we knew what the experts were recommending, change was still slow, if there was any change at all. In my opinion, what we are dealing with is a problem connected with governance, data governance, or the governance in terms of how we make decisions and how we make our own contributions to change. In a hierarchical view, we often imagine, well, most of us imagine, most of the shareholders present here, we all are shareholders in a healthcare system, so quite often we believe that deciding on change in the health system is organized in a hierarchical manner. We have this image of redemption, that the current minister will be someone to redeem us. The power of decision-making does not lie with a savior that will redeem us. It is much more fragmented in various other associations here, like the National Healthcare Institute, insurance companies, the minister, and various other stakeholders, each with their contribution to the health system. This is a way of governing and something that we want to achieve with a democratic system. We are not just following one single interest, but a multitude of interests. But in order to make this joint decision-making successful, requires mutual trust among stakeholders. And this is the point that is missing, mutual trust. In practice, we see this in what Mr. Leite previously mentioned as regards the public servants going into the private sphere where they think they are not respected enough and they think that the environment is not responding to their needs and requirements. They did not develop this sense of trust. if we have the sense of trust, we can gradually also develop the sense of responsibility, co-responsibility. And so all stakeholders, they will not just look into the Minister of Health as the only owner of the health system and the only decision maker. Well, in your work, you've also dealt with the so-called evidence-informed decision making, a concept we've been discussing for years. I think that in Slovenia this concept is not really succeeding. Why? Why don't we have a sufficient level of evidence-informed decision making? Now, one of the myths that we need to break is that evidence, data, professional literature can provide to us answers in terms of concrete solutions we should implement. This is a technocratic attitude, ignoring the fact that we have different values, goals, approaches. Each stakeholder is, in fact, following their own objectives and targets. We need to distinguish here. We must delve into a moment of professional discussion as to what is possible and what the consequences of our decisions will be. But the very first question is what kind of society we are striving towards. An example of Nutrias, for instance. The point of Nutrias, those rodents that are too abundant, allegedly, in Slovenia, leads to a very heated discussion and to either making right or wrong decisions or not making decisions at all. Well, thank you very much for this first round of your contributions. Since we are limited in terms of how much time we have, I will now give the floor to the audience if anyone wants to offer a comment or raise a question. And I don't think I can see you well enough because we are under the lights. Mr. First. I am an advocate of patients' rights from the region of Gorenska. Data, trust in data is something that we've been discussing here today. I've been dealing with this in my daily practice. Patients call in, they say, according to this register, I should get an appointment in 30 days, while the National Institute of Public Health's IT system provides a completely different data. How come there is this discrepancy between the various register and databases? Thank you very much. This is probably a question for Mrs. Zaletel. Well, as regards the waiting times and the discrepancy between what the Institute has and the various providers publish, if the details are not consistent, it just means that the provider you are referring to is not regularly updating the details of the waiting times. We at the Institute are not editing this data at all. If you are referring to Gorensko, the hospital of Jesenice has had quite some problems with that, from what I know. And as I said, the quality of this data depends on the specific providers. Well, as regards the quality of data,
dobivamo.
The quality of the feedback is extremely significant unless the providers receive feedback as to why a certain set of data is being used. They cannot improve. Dr. Marušić. Well, data is high on the agenda today. We must know that data is the basis for information. And the very important question is who creates information from data? Are we dealing with the right sets of data? Do we have the right clients requesting data? The Slovenian Institute of Health Care System just recently published data regarding physicians, doctors, and their performance, the number of interventions they did, and I called for that years ago. The Institute was the first one to publish this data. Whoever commissioned the publishing of this data must have followed a specific objective, and I think that this was not a bona fide objective. This was a negative objective because it stirs a lot of anger and criticism in the Slovenian public. It was not clear why, for what purpose this data was released. If we have in the future cases where some of this data even deteriorates for certain hospitals, what do we do then? My opinion is that we must handle data with care. This data about healthcare professionals must be disclosed in a very thought-through manner in order not to cause any unnecessary fear. If we are looking at the level of complications in several surgeries, having surgeries without any complications is mission impossible, and just publishing data on the lack or the number of complications in surgeries without explanations is misleading. Thank you very much, Mr. First, or any other member of the audience.
Ta preostali čas, ki ga imamo, to je še 10 minut,
well,
daje dovolj časa,
10 minutes or so, which is, I think, enough for your concluding remarks.
Slišali od uvodnih govorcev,
regarding everything you've heard today, in the lectures and through the discussions. Perhaps Dr. Marušić. Well, first of all, I should tell you that I've found this conference very enjoyable. The lecture given by three eminent international experts were inspiring, and they led me to believe that after all, the difference between the world and Slovenia is not that big. Our colleague from Portugal made some specific comparisons between Portugal and Slovenia, and that was good too. So, a very enjoyable event. Some figures were especially highlighted for me, especially regarding the 20% of wasteful spending in the healthcare. We also heard about the genome, and it is in the genome of the Slovenians that we are quite often unhappy. We are not unsatisfied. Our Roglic won Giro d'Italia. He won that last weekend. 2 times he won Vuelta, and still there will be people who will not be happy with this achievement, but we say, well, but he hasn't yet won Tour de France. So instead of focusing on what is good and even improving that, some people are just trying to destroy and criticize what is good. So some people will not be able to accept change. And change must also happen in terms of the terminology, the words we are using. We should shift away from speaking about the sick or patients. We must speak about health. We must speak about the positive things.
Podaljšamo zdrava leta
Well,
življenja, ne?
also you mentioned at the beginning that we must work on expanding the healthy years of life. Given the nature of Slovenia, we will also be slightly less healthy than we would desire, right? Well, in Slovenia, according to surveys, we are trading worse in terms of how satisfied we are with our health. Perhaps we should just accept our history. We know that throughout our past, the health system relied on the primary care. Without the primary care level, our healthcare system will not survive. It is also important to change the system of indicators that we are using to assess our health system. We are still using the indicators arising from 1985. It is the same as if our top cyclist Roglic was using a simple calendar instead of digital time meter. So terminology should be changed. I was very fascinated the last time, on the last occasion, when I entered a plane and I was greeted personally by the pilot. So this is personalized healthcare. This is personalized care, and it should be brought also to the healthcare system. Personalized. We are dealing with persons. It is not just about money, it is also about the attitude. We must work and use our history. Those who would like to change everything and just negate history will become a history soon enough. Well, Mrs. Zaletel, you are celebrating the centenary of your institute just today. What is Institute's future? Well, it is difficult to say at this moment what the future will bring for our public health institute. But when it comes to data, I know what is important. Firstly, the quality of data. We are very critical when it comes to the quality of the data that we have in our hands. And we are often criticized, for instance, if we don't have every single little piece of information about every single doctor and resident, our statistics are said to be bad. That is not the case. We are speaking about data that are representative of the situation. The same goes for the data about the waiting lists. It's not that important whether we capture all that are waiting. The important thing is that we have, in general, too long waiting periods. In Slovenia, we know how many family doctors, general practitioners we have. Although some quarters criticize us, we don't have that data. But we must know, or we must pose the right questions. Do these family doctors work in teams, and how effective are these teams? And thirdly, we must distinguish trees from the forest, and the real question is, are we able to do so on the basis of the current set of data? Mr. Kanovic? Thank you very much. In my opinion, in terms of our organizational culture, we are still adhering to collectivism, less to individualism. Collectivism seems nice when we expect the society to collectively take care of us, but individualism fails us when we are unable to assume responsibility for ourselves. Every one of us should ask themselves the question as to what can they do individually to improve in their environment and for themselves as well. Specifically, in terms of the data held by the National Institute of Public Health, if they collect systematically data about healthcare providers, the next step is to say what can this data be used for to improve the system.
Jaz bi pa naredil majčken odklona, nisem uspel nič ekstra govoriti o digitalizaciji, ampak
Thank you very much for the floor. Now, I did not touch upon digitalization enough today, I know. So I would conclude by saying the following. I believe that there is a synergy between individuals, the tools that we have and will have. There is a synergy and there must be a synergy. In the environment where I live and work. I work as a medical doctor. Like all other forms of evolution, we too, in terms of digitalization, are amidst evolution. If we were able to accept that we are now in a new reality, that we cannot go back into the past, and that we must learn to use what digitalization brings to us, I think our way into the future would be easier. If you've ever seen science fiction films, you saw how various space shuttles were used to fly out into the space. The films did not show you how these space shuttles were made, so the usage was important. Thank you very much, Mrs. Španić. Well, we know that we have an abundance of data. Smartly using them is a key challenge, and I agree with Dorian. The use of words is important. The way how we communicate is important when it comes to breast cancer. It is important to know where breast cancer surgeries are made, by whom, what outcomes are provided by specific providers. And I am sure that every patient, if they had the right data available, would decide on the best possible care, even if this was not provided in the nearest facility. We should stop protecting local silos. We should start sending people, patients, into competent institutions. And in order to do this, we need to use the data available in a smart manner. Data are underlined by individuals, by people. Thank you very much. Now, Dorian mentioned in the discussion that he was very glad not to listen too much about the numbers of hospitals, interventions, surgeries in the morning. But I'm an economist by profession, and we also heard about sustainable systems without listening much to the term financial social sustainability. We heard that we need to build competences. We need committed and loyal human resources, not only providers, but also decision makers. The healthcare strategy is, by definition, a strategy of stakeholders, which means that we need cooperation and constructive discussion. Without that, we cannot imagine a sustainable, flexible, adaptable healthcare system. And that is frustration number one in Slovenia. We are speaking about indicators, ratio, head fees that are old, decades old, that is. We need a revised set of indicators and measures in order to have a sustainable healthcare system. By that, I'm concluding the round table, and thank you very much for your attention.
Kar ostanite, ste krasno ozadje.
Thank you very much. You can stay here. You provide for a very nice background. Just a couple of concluding words. Time, in addition to health, is an important asset. So we are just concluding by giving the floor to the General Secretary of the Pharma Forum, Mrs. Barbara Stegel. Thank you very much. It was a pleasure to listen to these excellent and inspiring ideas and discussions. I would like to extend my heartfelt thanks to all the speakers at this 12th conference on the value of innovation. Many thanks to everyone who has come here in person and to all those of you who are with us online. Thank you very much for your perseverance, for following us and supporting us for 12 years. Thank you for encouraging us in our efforts to create the best possible healthcare system in Slovenia. And last but not least, thank you for giving innovation the right place in that system. In these conferences, we are really making our best to ignite the spark of momentum and to make this spark a chain reaction, bringing on a lasting flame and fire that will bring us further on to a better healthcare system. There is a Slovenian saying that if you want to set others on fire, you have to burn in fire yourself. And we've been burning with passion, with fire for 12 years. Without your support, we would have run out of energy long ago. In these critical times, not only in Slovenia, but in Europe as large, we are sometimes surviving because of our self-perseverance will. We, at some point in our lives, are all patients, and as patients, we deserve a good, flexible, adaptive healthcare system. We have innovations all around us. There is artificial intelligence available in medicine, genetic therapies. All these are realities of today and tomorrow. But all this is just a tool, and these tools should be available to all of us, and we must learn to use them. We must improve our literacy. Improvements will have to happen either by love or by force. Everything around us is dancing. The earth is dancing. We are dancing. We have great cyclists, not only Roglic, we also have Pogačar, and we have other excellent dancers, including ourselves, but we must dance to the tune. We must recognize whether we are dancing a foxtrot or a cha-cha-cha. Speaking about future-proof health system brings with it a certain level of risk. Just living itself is a risk, and we must take it on board. Now, we always try to minimize the risk, rationalize the risk. At the end of the day, however, we must take it on board, accept it. Without a risk, there is no life and no development. All our conferences, however, are devoted to that last notion, development. And we are not giving up. We should not give up. We do not want to give up. We are standing here in front of you. That's all we can do and we should do. And this is something that Martin Luther said more than 1500 years ago. Mirsha just a few moments ago mentioned the personal accountability. We all believe in that. The future is embracing us, it is coming closer, and who can to a nation who persevered for 1500 years because of its stubbornness and skills and industrial way of living, ourselves, we are the ones who will survive. Our common value is health. That is why I am concluding by saying, let us join our forces. Let us make the next step together with joined forces. Thank you very much.
Hvala lepa. Moj zaključek bo čisto kratek in optimističen.
Thank you very much. On an optimistic note, I come from a town where we only got electricity 2 months before I was born, and I still consider myself as being young. At that time, we thought electricity was a science fiction. For some other people, what we discuss here today may seem to be a science fiction. I'm sure that when we get to the 22nd edition of this conference, all this will be reality. Thank you very much, and I call for action with joint forces.